Good evening, everyone, and good morning to everyone. We have now landed up to the webinar 5. It's the IPNA webmaster series on pediatric tubular disease symposium. And today we have all the experts and teachers of teachers who's going to speak with us. And today we have the exciting polling session. And I request Dr. Amrish to introduce Dr. R.N.Srivastava, who's going to be our chairperson for the webinar series.
Thank you, Dr. Kalavani. This is Amrish Jain here from Children's Hospital of Michigan. As Kalavani mentioned, this is webinar series 5, and it is my honor and privilege to welcome Dr. R.N.Srivastava, who has graciously accepted to be the chairperson for today's session. We know that he needs no introduction. He is the pioneer in the field of pediatric nephrology in India. He has more than 50 years of experience in nephrology, and he is still actively practicing pediatric nephrologist. He has received multiple awards from Indian Academy of Pediatrics, Indian Society of Pediatric Nephrology, International Pediatric Nephrology Association, and of course, to mention his most recent Lifetime Achievement Award. He has published numerous articles, book chapters, and served as editor of textbooks. To mention, he has mentored at least 2 or maybe 3 generations of pediatric nephrologists, and I think I consider myself as the 3rd generation of pediatric nephrologist. So thank you so much, Dr. Srivastava, for joining, and I'll hand over the session to you.
Thank you, Rish, very, very kind introduction. Yeah, it's been a long innings here in India, but very satisfying, very satisfying. It's development of the pediatric nephrology here. My pleasure to introduce Professor Soundararajan, a very senior nephrologist, now senior consultant at Apollo Hospital, Jubilee Hills, Hyderabad. I would say a fellow consultant at Apollo. He has 35 years of medical experience, teaching experience in various faculty positions, and the head of department of nephrology 25 years as the Ramchandra Hospital, and again guided so many students and published various articles. He's a member of the governing council, the Indian Council ICMR, member governing body of PGI Chandigarh, which is a very prestigious appointment. Won the Dronacharya National Award in nephrology and a Lifetime Achievement Award from Dr. MGR University. A very distinguished, very senior nephrologist of our country. So he is to talk on, he is to introduce. Is that it, Dr. Mani? Dr. Yeah.
Thank you, Dr. Srivastava, for the nice introduction. I think at the outset, the rising star in pediatric nephrology in South India and Madras, Dr. Kalavani, and other doyens in the field of pediatric nephrology, Dr. Nammarwar, the father of pediatric nephrology. I think it's a privilege for me to join this forum of pediatric nephrology. It's my proud privilege. I'd like to introduce Dr. Mattoo. He's a professor of pediatric nephrology, chair of professor of pediatric urology and Department of Wayne State University School of Medicine. He has a special interest in nephrotic syndrome, PU reflex, and hypertension, cystic kidney. Almost has contributed to all the reputed journals. I think he's also the editor-in-chief of Update, I think, whom we have been admiring. I think I really think it is a privilege for me. I am a close follower of Up to Date, and I feel it's a great honor to meet him and talk to him and introduce him on this forum. I think the topic of the day is going to talk to us about the renal tubular acidosis. How do I approach? Thank you.
Okay, well, thank you very much, Amrish, Professor Srivastava, Dr. Soundararajan, Dr. Nimmalwar. It's always a great pleasure to be amongst friends. And I am so impressed with your center's commitment to UpToDate. I'm going to actually share that with UpToDate office. I'm glad you like it. And as I mentioned earlier, I like it too, because a lot of effort goes into putting together what you see in it. I am so happy that you are, again, getting people together this year to share their expertise in pediatric nephrology. And it's a great way to get people together and share our experiences and knowledge that we have, and some of us accumulated over decades. And we are so keen on sharing it with younger generations. So again, thank you very much for inviting me. So if I can now pull up my presentation. But this is Dr. Ganesh, and she gave me this, and she had mentioned that I'd be talking about renal tubular acidosis, but then a couple of days ago, she told me that this is the title, How Do I Approach? So I had to redo my presentation. In fact, like 15 minutes ago, she asked me if I could share her slides, and I was still actually working on it. So before I get into how I approach it, let me see if I can forward the slide. Okay. Before I talk about how I approach it.
Dr. Mattoo, sorry to interrupt. We cannot see your slides. If you could share it again. We just see a blank screen.
It tells me here that you are screening slide, and so let me stop sharing.
And you could try it again.
And then let me just try again. Do you see it now?
No, I think you'll have to select your presentation, which presentation, because we can see a blank slide, but not the presentation.
Okay. Does it show now?
Yes, now you can put in the slideshow and that'll be perfect.
Okay.
Thank you so much, Dr. Mattoo.
Okay. All right. So before I talk about my approach to RTA, I want to give a little bit of physiological background. I promise I won't bore you with this. When we talk about renal acidosis, there are two different issues we are talking about. One is the acidosis that we see with chronic kidney disease. And as you know, with chronic kidney disease, there is a decrease in GFR, and there's a problem in filtration and excretion of acids by the kidneys. And it's predominantly ammonia, but there's a problem in bicarbonate absorption, and there are many other things that happen, and patient becomes acidotic. But mind you, these patients have a decrease in the GFR. And in earlier stages of acidosis due to chronic kidney disease, the anion gap may be normal. And that's because the kidney compensates by retaining more chloride. But as the kidney disease progresses, the anion gap increases. The other type of acidosis that we see in relation to kidneys is the renal tubular acidosis, and that's the topic for today. And in these patients, the GFR is normal. So they don't have a CKD. Their GFR is normal. And the anion gap is also normal. And sometimes in early CKD, with normal anion gap, patients may be misdiagnosed as RTA, but that happens rarely. And this is a very familiar figure that you must have seen a million times. The proximal tubular cell, when you look at it, there is no transporter for bicarbonate reabsorption. And on daily basis, we as adults filter like 4,000 to 5,000 milliequivalents of bicarbonate. And yet there is no mechanism for direct bicarbonate absorption. And if all that bicarbonate came out in urine, we wouldn't survive more than a few minutes. So the way kidney helps reabsorb that bicarbonate is by secreting H ions. It joins the bicarbonate to make it carbonic acid. Then we have carbonic anhydrase. I don't need to go through that. So on the apical side, we have sodium hydrogen exchanger that plays a predominant role in H ion excretion in the proximal tubule. And then we have carbonic anhydrase 4 on the apical side. Intracellularly, we have carbonic anhydrase 2. And then on the basolateral side, we have sodium bicarbonate co-transporter. And that's how the bicarbonate gets resynthesized intracellularly and then reabsorbed. And the H ion that we secrete in the proximal tubule is a lot more. This is one of my favorite questions with the students. When I ask them, okay, tell me about H ion excretion, they right away think of the distal tubule. The H ions that we secrete in the distal tubule is a fraction of what we secrete in the proximal tubule. But the difference is that in the proximal tubule, there's no net loss of H ions, because all the H ions, we secrete like 4,000 to 5,000 milliequivalents of H ions in the proximal tubule. And the reason there's no loss of H ions is because it all is used in resynthesis of bicarbonate. Otherwise, we secrete a lot more H ions, a lot more in the proximal tubule, but it does not make difference for H ion excretion because the net balance is 0, it's all reused here. The other thing to keep in mind is that of all these transporters and enzymes, it's only carbonic anhydrase 2 that you see both in proximal and distal tubular cells that maintain our space balance. So just remember that CO2 is common to both, and I'll tell you why that's important in a minute. Now, the H ion excretion in the distal tubule, which is in the cortical collecting duct. And here on the basolateral side, on the apical side, we have H ion secreted by hydrogen ATPase and hydrogen potassium ATPase. And both of them together, as I mentioned earlier, they secrete a fraction of H ions compared to the proximal tubule. But again, the difference is that this H ion does not get back into the blood as bicarbonate. This is what changes the pH of the urine. And this H ion that we secrete in the distal tubule joins mostly, it's buffered by phosphate and ammonia. But phosphate actually plays a more prominent role in its buffering. But as we become acidotic, ammonia picks up more speed. And in acidosis, it's ammonia that becomes a lot more important. So we have H ion excretion by H-ATPase and hydrogen potassium ATPase on the luminal side. Then you have this carbonic anhydrase 2 intracellularly, like in the proximal tubule. And as I said, that's the only common thing between the two cells. And then on the basolateral side, unlike sodium bicarbonate co-transporter in the proximal tubule, we have chloride bicarbonate exchanger. So there is some bicarbonate actually resynthesized in the distal tubule as well. So on one hand, we have plenty of H ions produced in the proximal tubule, but they don't make any difference to H ion excretion because it gets reused. And there is some bicarbonate excreted in, some bicarbonate regenerated in the distal tubule that actually goes into our system. So distal tubule does help us with some bicarbonate level as well. And with that background, you all know that there is a distal type of RTA, and we call it type 1 because this was the first one to be identified. And I don't know why we couldn't rename them because it becomes confusing for students. Then we have proximal RTA, which is type 2. Now, some people argue about type 3 RTA, which essentially is when you have both symptoms of both proximal and distal RTA. But I showed you that carbonic anhydrase 2 is present in both proximal and distal cells. And when you have a problem with carbonic anhydrase 2, then you could get symptoms that are a combination of both proximal and distal RTA. And the disease that causes something like that is common in the Middle East, and I've seen a few patients. It's called osteopetrosis or marble brain disease. It's a very interesting entity. They have deficiency of carbonic anhydrase 2 and can present with combined proximal and distal RTA. And then there is hyperkalemic RTA, and that's where I see lots of people getting confused. Now, there are two types of, I'm going to spend a minute or so on this. There are two types of hyperkalemic RTA. When we say type 4 RTA, that's when you have hyperkalemic RTA in relation to aldosterone problem. That's type 4. But then there's another type of hyperkalemic RTA, which is actually called voltage-dependent distal RTA, which many people classify as subtype of distal RTA, except that distal RTA normally doesn't have hyperkalemia. But this is a subtype of distal RTA that causes hyperkalemia. And the problem is that there is a defect in distal tubular sodium reabsorption. And when that doesn't happen, you don't create a negative voltage, negative PD in the lumen to help excretion of H ions and potassium. So there are two types of hyperkalemic RTA. And when you say type 4 RTA, you are talking about RTA related to aldosterone deficiency or aldosterone resistance. But then there's another type of hyperkalemic RTA, which has nothing to do with aldosterone. And it's because of problem with sodium reabsorption. And this is the one that is often associated with so many conditions, medications, obstructive uropathy, and there are lots of conditions that can cause this voltage-dependent distal RTA. And if you want to differentiate between the two, the voltage-dependent RTA behaves like distal RTA. The urine pH doesn't drop. Whereas in type 4 RTA, the urine pH can drop and patients behave more like what may happen in proximal RTA, and I'll elaborate on that a little bit more. So this is distal type 1 RTA. It may be isolated or it may be secondary to lots of things. And isolated, it may be a sporadic thing, or it may be inherited. It can be recessive or dominant. And when it's recessive, it may or may not be associated with deafness. And we see a few patients here in Detroit area because we are close to Dearborn, that has the largest Middle Eastern population. with a high rate of consanguinity and more autosomal recessive disorders. So that's the kind of RTA we tend to see more in our area. And then there are lots of conditions that cause secondary distal RTA, and I don't need to get into that. And then similarly, the proximal RTA may be isolated, and it can be very transient, and that's not uncommon in infants or younger kids because of immaturity of sodium hydrogen exchanger. So you may have an infant who seems to be having a proximal RTA, and then it gets better as the kid gets older. This is what that kid has. But then there are other types that are inherited. Again, it can be recessive or dominant. But then you can also have proximal RTA where it's not just the loss of bicarbonate, there is loss of other things in urine, particularly glucose, phosphate, uric acid, and everything else. And those patients have Fanconi syndrome. And then there are different types of Fanconi syndrome, and we don't want to get into that. And it may also be idiopathic or secondary. And now one of the conditions I want to elaborate a little bit is what may happen sometimes in vitamin D deficiency. And I assume that you must be seeing a lot more such cases in India because I've seen a few in here in Michigan. When a young kid has vitamin D deficiency, the PTH level increases, and that sometimes causes increased proximal tubular loss of bicarbonate. So a patient with rickets may sometimes also have what may seem like proximal RTA. But the good thing is when you take care of rickets, the PTH level drops and that RTA goes away. And would be interesting to see a publication from India on something like this because it must be very common there. And then the hyperkalemic RTA, as I said, type 4 is because of aldosterone deficiency or resistance. And the commonest type of type 4 RTA actually I have seen is in babies and infants. Again, because of tubular maturation. And it doesn't last very long. And it gets better as they get older, a year or two of age, and it goes away. And then it may be there because of mineralocorticoid deficiency or aldosterone resistance, and we don't need to get into all that. And then we talked about the voltage-dependent distal RTA. So when should we suspect someone having RTA? Well, it generally happens two ways. And in the US, it generally happens because someone has done a blood test for some other reasons and finds that the bicarb is low. And yeah, when you look at the blood chemistry, bicarb is low, certainly, and you do the anion gap and it's normal, yeah, you need to think of RTA. But then there may be clinical symptoms that patients may present with, which we generally don't see in the US, but could be common in India. And failure to thrive would be a very important clinical manifestations. And then you have other sign symptoms that can raise suspicion of patient having RTA. So now coming to the title I was given. So how do I approach a patient with RTA? And I'm going to share with you exactly, and Amrish will be my witness to tell you that this is how I approach a patient with RTA. And I believe he does the same thing. So let's think of a patient who had labs done and is found to have metabolic acidosis. And the referring physician thinks, oh, the patient has RTA, and the patient is sent to me. The first thing I would want to see is if the patient is on treatment. If the patient is getting bicarbonate, that's a whole different thing then. I may try to decrease bicarbonate, I may try to stop it before I make the final diagnosis, but let's not get into that. Let's talk about a patient who is not on any treatment. What I would look at is, okay, what's the anion gap? And to be honest with you, I never calculate anion gap because you don't need to do that. If you look at the equation down on the slide, anion gap is sodium minus chloride plus bicarbonate. So if your anion gap is normal, sodium hasn't changed, bicarb has gone down, the only way anion gap would be normal is by chloride going up. So for that reason, normal anion gap metabolic acidosis is also called hyperchloremic metabolic acidosis. So I don't even calculate anion gap, I just look at the chloride. If the chloride is increased, the anion gap has to be normal and patient has normal anion gap metabolic acidosis. So that's what I would look at the labs for. What's the bicarbonate, what's the chloride? And then I would look at potassium. Okay, is the potassium normal, low, or high? Because that would tell me if patient could be having hyperkalemic RTA. So this is the blood test patient has come with, and this is how I would interpret that. What would I do? Well, obviously, I would want to repeat the labs, make sure that bicarb is low, because sometimes there may be some lab errors. Other times, labs may have been done a long time ago. So I would repeat blood chemistry. I would check creatinine. I would check calcium, phosphorus, alkaline phos, just the routine chemistry. I would check vitamin D25 level. Then I would get a fresh urine specimen. And the fresh part is very important because you don't want a urine specimen that has been sitting there for a few hours. I would get a fresh urine specimen from the patient and do dipstick examination and see what the urine pH is. And then since we got a urine specimen, I would send it for chemistry to check urine anion gap and urine calcium creatinine ratios. And that will take a day or two to come back. But the urine dipstick result will be available to me within minutes. And then I would ask for ultrasound examination. Now the urine dipstick, if it shows me that the patient's urine is alkaline and the patient has acidosis, assuming that the labs patient came in with are very similar to the labs I sent, and patient has normal anion gap metabolic acidosis, there's no reason why a normal kidney will produce alkaline urine in someone who has acidosis. So if the urine is alkaline in such a patient, your patient has distal RTA. You already diagnosed the condition. You don't need to do any fancy stuff. Okay. On the other hand, if the urine pH is acidic, then the renal response to acidosis seems appropriate. But then it does not rule out the possibility of proximal RTA. And I'll tell you that in a minute why. And then also on the dipstick, I will want to make sure that the patient does not have glucose in urine. Because if there is glucose in urine, then I may be dealing with Fanconi syndrome. If there's no glucose in urine, I'm not dealing with Fanconi syndrome. So by now, on the first visit, just looking at urine and assuming that there's nothing wrong with the labs that patient came in with, I have already diagnosed distal RTA. But I'm not sure about the proximal RTA. Now, this is a very important slide that very clearly shows what happens as we become acidotic, what happens to urine pH. This is bicarbonate, plasma bicarbonate, normal at 25, and you can see as I move left, the bicarbonate level drops. And then this is urine pH, this is alkaline, this is acidic, 4.5 pH. So as the serum bicarbonate drops, the urine, now bicarbonate is dropping, patient is becoming acidotic, the urine pH right away starts dropping because you are trying to get rid of acids. That's the appropriate renal response. And you make very acidic urine. In distal RTA, the bicarbonate drops, but the urine pH does not change. So even when patient's bicarb is very low, urine pH is still alkaline. So that's why it's so easy to make a diagnosis of distal RTA. But in proximal RTA, what happens in proximal RTA is 25, around 25 is the normal threshold, renal threshold for bicarbonate reabsorption. I mean, if any of us took more bicarbonate, let's say we took half a kilo, not that I want any of you to do it, but let's say we took a bolus dose of bicarbonate, our blood level will not increase because kidneys will get rid of it. And the reason for that is this is what our threshold is. Anything, the moment blood level starts increasing, kidneys filter the rest to keep level normal. What happens in patients with proximal RTA, their threshold is lower. So let's say instead of 25, now the threshold is 20. It's never 0 because then we won't survive. So let's say in proximal RTA, someone's threshold is 20. So anything more than 20 in this patient is going to come out in urine. So this patient's serum bicarbonate level will be 20. And if you look at urine pH, between 25 and 20, although the patient is acidotic, but the urine is not becoming acidic. But the moment patient hits the renal threshold, the pH starts going up. And the reason for that is because the distal tubule in this patient is normal functioning. So now the delivery of bicarbonate to distal tubule is what the distal tubule can handle. And the urine pH drops. So in proximal RTA, initially, you will have an inappropriately high urine pH for acidosis, but then once the patient crosses the threshold, you will have appropriate acidification. So if you happen to see the patient here, then you will see, okay, the patient is responding normally to acidosis. If you happen to see the patient here, you will say, well, this patient has proximal RTA. And if you do not have any other way of investigating patient with proximal RTA, what you could do is, let's say you have a patient with bicarbonate of 15, you start the patient on bicarbonate and watch the serum bicarbonate level and urine pH. And as the serum bicarbonate gets better, as you start getting into this zone, you will find that the patient still has alkaline urine. So you can diagnose patient with proximal RTA when you start the treatment. And you don't need any fancy testing. So anyway, it's very important to keep this in mind. Now, I saw this patient in the clinic. I did the urine pH, and patient has either distal RTA, or I'm not sure about the proximal RTA, but this is normal anion gap acidosis, I would start the patient on treatment, and the usual dose is 1 to 3 milliequivalents. It doesn't matter if it's proximal or distal. And then I get the results of the requested investigations that I sent from the first visit. I will look at the, now, what I'm saying here is what applies to most patients. There are exceptions in few cases, and I don't want to get into that because those are rare occurrences. So I would have the results of the urine anion gap, and you don't need to do any calculations here. It's positive or negative when you are looking at RTA. Normally, the anion gap is positive. We excrete more sodium and potassium than chloride. So we have more sodium, potassium in urine than chloride. So it's positive. That's normal. And in distal RTA, it's also positive. So the anion gap, urine anion gap, does not help you with the distal RTA diagnosis. But if it's negative, which means there's more chloride excretion, then you have proximal RTA. So when I get these results, and if it's negative, and pH was not helpful to me during clinic visit, now I know that patient has proximal RTA. And there's a reason why it becomes negative, because you have more ammonium excretion, and ammonium comes out with ammonium chloride, ammonium chloride. That chloride, increased chloride in urine, causes the, so it's a surrogate marker for ammonium excretion. We are trying to assess if there's increased ammonia excretion in this patient by looking at urine anion gap. That's all we are trying to do. So just remember that it's negative and proximal, otherwise it doesn't help. And then urine calcium creatinine ratio that I sent from the clinic, it doesn't change in proximal RTA, but it can be increased in distal RTA, because those are the patients who may have nephrocalcinosis, may have nephrolithiasis, depending on at what stage they present to you, and can have increased urine calcium creatinine ratio. So this also helps make a diagnosis. And then I asked for a kidney ultrasound examination, and what I'm interested in is if the patient has nephrocalcinosis or lithiasis, again, that's something that will tell me that the patient has distal RTA. And if it is distal RTA, I want to have a baseline on nephrocalcinosis, nephrolithiasis, because when I repeat it in a year, I want to see if it's getting better. So these are the investigations I would do in the clinic. Then there are other investigations that one can do in selected cases, but you don't need to do them. Yeah, genetic testing is becoming increasingly popular, and it helps pinpoint the kind of RTA the patient may have. So if it's possible to do it, I would encourage doing it, but you don't need it. It's not an absolute necessity for clinical diagnosis or patient management. And these other tests, I've done a few of them decades ago, but not since, because I don't need them. So what do I do during patient follow-up? And this is one of my favorite teaching points for residents. In a patient with acidosis, if you are not doing a good job, patient doesn't grow. So the first thing I look at these patients during clinic visits is, how is the kid growing? And if I see kid growing well, I feel good that, okay, maybe I'm doing a good job, but then I also feel better because I know that the family is giving the medication to the child. Because many times, no matter how hard you work, patient may not get the medication, particularly with proximal RTA, because you need a lot more bicarbonate in proximal RTA. You know, in proximal RTA, you need more than 10 to 15 milliequivalents per kilogram. And the reason for that is because the primary reason for proximal RTA is bicarbonate loss in urine. So you need a lot more bicarbonate. Unlike in distal RTA, where there's no problem with the proximal tubule, and you just need enough bicarbonate to neutralize the acid that you are accumulating. So the dose is usually less than 4 or 5 milliequivalents per kilogram. So particularly in proximal RTA, there can be compliance issues, although in distal RTA it can also happen, but a lot more in proximal because you need to do a lot more bicarbonate. And just looking at patient growth tells me if we are doing a good job with a patient. One has to look at patient tolerance, compliance. Is the patient getting medication? Is the patient tolerating the medication? It's no point prescribing something if the patient keeps throwing it up. And then on every visit, I do urine pH. And the reason for that is, now let's say you do have a patient with RTA and he or she needs X amount of bicarbonate. And then you check the levels and you keep on increasing the dose. And instead of X amount of bicarbonate that the patient needs, you are giving 2X amount of bicarbonate. You won't see any change in serum bicarbonate. You'll think, okay, you're doing a great job. What happens that extra bicarbonate the patient is getting, it's coming out in urine. It's the same scenario that would happen to you and I taking extra load of bicarbonate. It will just come out in urine. But then with so much bicarbonate coming out in urine, the urine pH is going to become more and more alkaline. And as you hit pH of 7 or higher, you significantly increase the risk of phosphate stone formation. Now, remind you, patients with RTA generally are at risk of calcium stone formations. But as you start treating them, you may be lowering the risk of calcium stone formation, but now you are increasing the risk of phosphate stone formation. So it's important to monitor pH, and you'll be surprised how often you will find that you could back off on the dose of bicarbonate your patient may be on, keeping serum bicarbonate level normal at the same time. Naturally, I would check the labs to see what the blood chemistry is doing, but the important point I want to make here is you must correlate the lab results with the timing the patient gets the medication. So if patient gets medication at 8 o'clock in the morning and you are checking labs at 8:30, it's going to be different from the labs you draw before the next dose is available. Now, you don't tell patient, okay, you have to give medication 20 times a day. You still want to give it according to patient and family convenience. But you need to figure out your doses based on what time the labs were done in relation to the medication given. So if you know that this was right before the next dose of medication was due, and the patient had normal bicarbonate on the last visit when it was done somewhere in between the two doses, then you may decide not to change the dose until you see the patient next time. Just keep that in mind. And then the dose of bicarbonate, obviously, you have to titrate based on serum bicarbonate level. And then as we learn more about the genetics of RTA, we know that some cases, particularly some cases with proximal RTA, may have some developmental issues. They also have some vision issues, and patients with distal RTA, some of them have hearing issues. If you have the genetic test, then you can be more specific about what kind of follow-up, but I generally ask for vision and hearing tests and keep an eye on their developmental, mental development myself. But vision and hearing, yes, you need to have that monitored. So we talked about the treatment in proximal RTA, because the dose of bicarbonate, as I mentioned, it can be very high. And sometimes you may have to add hydrochlorothiazide. It causes volume contraction and increases proximal bicarbonate reabsorption. So you may have to add some hydrochlorothiazide or indomethacin in proximal RTA. You don't need that in distal RTA. You may have to add potassium because when you start patients on bicarbonate, particularly, there may be increased potassium loss. And if patient is becoming hypokalemic, you may need some potassium supplementation, both in proximal and distal RTA. In type 4 RTA, again, you give bicarbonate, but remember I mentioned that it's very common in neonates and infants. I many times just put them on a small dose of Lasix. That helps lower their, because this is hyperkalemic RTA, so a small dose of Lasix helps lower their potassium and helps correct their bicarbonate until the RTA resolves on its own. In patients with voltage-dependent RTA, particularly, patient who has, say, for example, obstructive uropathy, has hyperkalemic distal RTA, I just put them on a small dose of furosemide and manage it by that rather than giving them alkali supplements. So there are ways to deal with type 4 RTA, and you may not always have to use bicarbonate. And sometimes what may look like RTA may not be RTA. And as I mentioned earlier, early chronic kidney disease, the anion gap may be normal. But then, once you do renal imaging and sometimes you have clues in calcium, phosphorus, alkaline phos, and then it's not that difficult to figure out that, the patient may have chronic kidney disease rather than RTA. But just keep that in mind, that the anion gap can be misleading in early RTA. But then never forget that sometimes the bicarbonate may be low because of compensation for respiratory alkalosis. And that can be very tricky in infants and very young kids. And I want to share with you a couple of patients. I don't remember if it happened during Amrish's time, but it may actually have happened even before him. So this was a 3-year-old male. The family had recently moved to Michigan and had been treated for proximal RTA for 1 year. And he was on bicarbonate dose of 3 milligrams per kilogram per day. And as I told you, for proximal RTA, you need much bigger dose of bicarbonate. When you see someone on 3 milligrams per kilogram per day of bicarbonate, you are not dealing with proximal RTA, you are dealing with distal RTA. So that was my first impression of this patient. Well, if at all he has RTA, it's distal, it's not proximal RTA. And family had brought me the labs, and you see the labs below that were done before bicarbonate therapy was started. And patient did have low bicarbonate. And if you try to calculate anion gap, I don't know what it is, but the chloride caught my attention. The chloride was not high. The chloride was 107. So I started wondering, does this patient really have normal anion gap? So I asked for a blood gas. And turned out that this patient had respiratory alkalosis. And that's the reason bicarb was low. And couple of visits more, and some phone calls and this and that. The patient was seen by genetics and then by neurology. Turned out that he had a mitochondrial disorder that was that was making him hyperventilate. So patient did not have RTA. Other patient, this was a hospital consult, 3-month-old female. Blood chemistry was done, bicarb is low, or patient has RTA, but look at the chloride. Again, I'm not calculating anion gaps here. And if we do, remember that in the first couple of years, the anion gap is higher than older kids. So, and the urine pH was 6.5. They had done urine pH on this kid. So it seemed that the renal response was not appropriate for acidosis if this patient did have acidosis, but that chloride kind of raised a red flag for me. Did a blood gas and patient had alkalosis, and turned out that the patient eventually, it took again some time before the final diagnosis was made. Patient had cystic fibrosis. So blood gas can be very helpful in making blood gas can be very helpful sometimes, and I would routinely do it in infants or a kid who is a year or two old, unless I have some other clinical signs or some labs that convince me that there's nothing else going on. So to summarize, RTA should be suspected in patients with normal anion gap metabolic acidosis with no other system, particularly GI. That's the first thing you want to make sure, because once you have GI problem, that can give you normal anion gap metabolic acidosis. It can also cause problem with urine anion gap assessment. So make sure that patient has nothing else going on. And then if you have alkaline urine in presence of normal anion gap metabolic acidosis, patient has distal RTA. You don't need to wonder too much about the diagnosis. Most patients do not need any sophisticated testing for diagnosis. You can diagnose most patients by simple tests, which are easily available in India. Be careful about overtreatment. For the reasons I mentioned, you don't want to increase the risk of phosphate stone formation. And serum bicarbonate wouldn't tell you if you're overtreating the patient. And blood gas, maybe I shouldn't have said maybe, it definitely is helpful. In young kids, where it may be problem collecting urine and things like that, make sure that you do a blood gas before you commit patient to bicarbonate therapy, or in cases where urine pH is borderline, things like that, do a blood gas. And then during follow-up, monitor patient growth and development, vision and hearing. These are extremely important. And with that, I conclude my presentation, and I'll be happy to answer any questions.
Soundararajan sir.
Thank you, Dr. Mattoo. It was an excellent presentation. I like your words. We don't need any sophisticated test for diagnosis. It's mostly a simple bedside diagnosis. We love to hear that word from the experts like you. I think I'm sure we, as our organizers feel, we'll take up the questions after the next lecture. That's what, Kalaivani, you feel comfortable?
Sir. Towards the end of the session is fine, no, sir.
Yeah, that's an excellent discussion of the subject, sir. I think we'll move on to the next speaker.
So can you stop sharing, sir? Tej, sir.
Sure, yeah. Hold on a second.
I have a great pleasure to introduce Dr. Manisha Sahay, who is going to give us the next talk on tubulointerstitial nephritis. She's heading the Department of Nephrology in the prestigious Osmania Medical College, Hyderabad. This is as old or as much old as Madras Medical College, right? It's one of the prestigious institutions in the state of Telangana. Obviously, 13 gold medals, 167 publications, more than 500 guest lectures. It's not a small number. So she's not only in the national arena, she's also in the international arena. She's editor-in-chief for Journal of Transplantation. She's in the International Society of Nephrology in the CME committee. Women in nephrology, it's a very upcoming united force in India. I think women in nephrology is coming up in a big way, not only in social life, politics, and probably in the footsteps of President of India. She's the Vice President for Women in Nephrology. They are doing a great job of late in the last 1 year. She's also President for the Nephrology Forum. She's a Fellow of Academy of Medical Sciences, Indian Society of Organ Transplantation, multiple awards, go on and so forth and so forth. I think I'll present to you Dr. Manisha Sahay to speak to you on the subject of tubulointerstitial nephritis and the current concept. Dr. Manisha Sahay.
So at the outset, thank you, sir, for kind introduction. You have always been encouraging since my student days, and you were my examiner in nephrology, and I still remember that tough examiner. And it's difficult to speak after Dr. Mattoo, who has been one of the most prolific speakers, wonderful orator, but I'll try to do my best. And I thank Dr. Ganeshan for inviting me here to talk about this topic. So I'll be talking about tubulointerstitial disease. And I begin with a case, 8 years child, and height is fine, weight is okay. He had fever and some respiratory infection, and he was diagnosed to have some lymph nodes in the neck 15 days back outside. He was initially given amoxicillin and clavulanate and also mefenamic acid at that time. And as is the practice in some places, in one of the small centers, he was initiated on ATT as well for the lymph node, and he has been on rifampicin and INH since 1 week. Now he came to the Department of Nephrology with loss of appetite of 2 days duration and swelling feet and face 2 days, and he was admitted for evaluation. And he brought with him some reports. The urine was 1+ protein, RBC were there, 3 per hyperfield, no casts, WBC around 10 per hyperfield, nitrate test was negative. He had a creatinine report of 1.1 milligram per DL. For that, he was referred. And ultrasound, what he carried, the report with him showed no hydronephrosis, normal size kidney. And with this, he came to our OP and he was admitted. So we all know that this patient, this child, fits into the definition of acute kidney injury. I won't elaborate on that by the creatinine and GFR criteria and the time duration. So that much is a given. And most likely, in OP, we thought that pre-renal, there is no significant history, no volume loss, nothing. Post-renal also, there doesn't seem to be any history. Probably it's some renal cause of AKI. And because the urine didn't show any proteinuria or RBC casts and the child was non-hypertensive, probably it's not a glomerular cause, probably not a vascular cause as well, because again, no hypertension, most likely urine output was good, and probably because he had sort of a bland urine sediment only with some WBC and minimal protein, the obvious diagnosis was acute tubulointerstitial nephritis. And I'm sure you're all with me till here. Fine. So now why we need to know about this acute tubulointerstitial nephritis. What is it? As the name itself says that it's involvement of tubules and interstitium, and itis shows inflammation. So there is inflammation in the kidney, inflammatory infiltrate is there, there is edema in the interstitium, that's called interstitial nephritis. And then you have, wherever the tubular involvement, the basement membrane gets involved, you have tubulitis. And collectively we call this as tubulointerstitial nephritis. Simple to understand. Is it common? So around 3% of renal biopsies showed this. And in papers from outside, in hospitalized patients with AKI, 15% is because of tubulointerstitial nephritis. It's an important cause of AKI in children as well and accounts for around 10% of all cases in that paper, which is mentioned there. However, recently it's increasing because of polypharmacy. So many drugs are used, and more likely also because of the increasing number of biopsies, where we can pick up the tubulointerstitial nephritis on biopsy. And this was a study done from UK, recent study, which showed that they had only 10 cases in the last 8 years. And I'll show you our data as well in India. So what could be the etiology of this tubulointerstitial nephritis? It may be because of drugs, most common. Infections, we are in India, this is also common. Then systemic diseases, autoimmune diseases, malignancy, and some special entities. So what does this child have? So what drugs can cause tubulointerstitial nephritis? So you can see a big list there, antimicrobials. And here you can see you have antibiotics. Initially we had methicillin, but now all the other groups of antibiotics can cause tubulointerstitial nephritis. Then you have antitubercular drugs, you have antiviral drugs as well. So all groups of drugs can lead to interstitial nephritis among the antimicrobials. What about NSAIDs? One of the important causes, almost all the agents, including the COX-2 inhibitors, which were initially thought to be safe. Diuretics, commonly used drugs in children, furosemide, thiazide, both of them can cause. Then upcoming anti-cancer agents, the immune checkpoint inhibitors, they are everywhere in oncology, in nephro-oncology, pediatric oncology, and they're an important cause of tubulointerstitial nephritis. Then anti-epileptic drugs, another commonly used group of drugs, phenytoin, carbamazepine, valproate, phenobarbital, levetiracetam, the newer drug also can cause tubulointerstitial nephritis. And apart from that, other common drugs, the proton pump inhibitors, the H2 blockers, commonly used drugs. And apart from that, allopurinol and few others. So there's a big list of drugs. And this child, the index case was on 3 of them, rifampicin, antibiotic, as well as he was given an NSAID as well. The second important group is infections, and bacterial infections, viral, parasitic, fungal, others. So again, all infections can cause tubulointerstitial nephritis. So remember, the list is long. I'm not going to go through all of them, but any infection can cause tubulointerstitial nephritis. So these include parasitic as well, fungal as well. The other ones, leptospira, mycoplasma, rickettsia, syphilis, so on and so forth. And now we have histoplasma added to it. Hydrated case reports are there. Adenovirus and BK virus post-transplant. Then the third important group is systemic disease, and common ones are sarcoid, Sjogren's syndrome, and systemic lupus erythematosus. Among malignancies in older people, we have multiple myeloma. Children, we can have lymphomas, and some special diseases, IgG4, tubulointerstitial nephritis with uveitis, and some others. So what does this child have? Let us see. So generally, how do these patients present? These patients of tubulointerstitial nephritis as we go along. So clinical features, you can see a host. Most of them have renal failure. The onset is generally between 1 to 2 weeks. But important thing to remember, late onset, as long as 18 months can be there with NSAIDs. 18 months is too long a time, and we forget the history of NSAIDs. Anti-cancer drugs are another group of drugs where the onset may be much later. So this is important to remember. Others present even first day. Rifampicin can cause even first day presentation. Then what is the common presentation? Renal failure is one of the commonest presentations, but you can see you have oliguria, not in all. Only 50% have oliguria, less than that. And then extrarenal symptoms. And again, remember, only 50% have extrarenal symptoms, not all of them. Even macroscopic hematuria can be there, which is present in a lesser percentage. So you can have a host of symptoms. Eosinophilia can be there on blood picture. All these findings can be there. So nothing is very specific. Okay, and what about some peculiar features? So most of the drugs can present like that, but NSAIDs, important to remember, even children can have AIN with NSAIDs. It occurs after months, as I already said, and nephrotic syndrome can be associated because of associated minimal change and membranous nephropathy. Generally, AIN, we don't see nephrotic syndrome, but NSAID is one group where you have to think of this entity, the associated MCD or sometimes membranous. Hematuria is rare and extrarenal are very rare in NSAID-induced AIN. Any other drugs where you can have nephrotic syndrome with AIM? It's another classical question. So NSAIDs, everybody knows. There are 4 other drugs, rifampicin, ampicillin, interferon, and ranitidine, where again you can have a nephrotic presentation. So please do remember that. Then antibiotics can sometimes present with a triad, fever, arthralgia, and maculopapular rash. It's becoming more and more uncommon. It used to occur with methicillin, but now these days we don't see it. So each symptom can present in less than 50% and all symptoms together less than 10%. So this classical triad is becoming very unusual. Now coming to rifampicin, can be identified by any typical features. This child was on rifampicin. So generally occurs after rifampicin intermittent use as directly observed therapy, very uncommon with the continuous use of rifampicin. So we have DOTS therapy and we have this sort of renal failure in India. Fever, myalgia, GI symptoms are common. Extrarenal manifestations are common with rifampicin. Thrombocytopenia, hemolysis, hepatitis, and the specific test is anti-rifampicin antibodies. So this also can be diagnosed, but again, if these features are not there, you can't exclude this. Fine. Any clues to the other diagnosis? Sarcoidosis. Again, sarcoidosis, 50% of extrarenal involvement. SLE, again, extrarenal involvement is common. And malignancy, again, you may have other features of malignancy, weight loss, etc. So this child just had fever, upper respiratory, and had a lymph node there. Can we diagnose any of this till now? No. Another important cause, as I said, was the Tino syndrome with uveitis. And here, classically, eye involvement is there. This child did not have any such features. This is generally because of chlamydia and mycoplasma. And uveitis may precede or succeed tubulointerstitial nephritis. Extrarenal features are common here. And this has a relapsing course. Another important clinical clue is jaundice with subconjunctival hemorrhage, and that is your leptospira, which is again a common entity in our country. And thrombocytopenia is common, the renal failure is generally non-oliguric, and hypokalemia is seen. So this is also important. So I was just discussing the common renal manifestations and extrarenal manifestations. How can we pick up the diagnosis? In this child, we did not have a particular clue. Now, what could be the renal manifestation? So as I said, AKI is most common, but you can have nephrotic syndrome. You can have nephritic syndrome, renal tubular acidosis, as sir discussed. Fanconi's can be there, electrolyte disturbances. Most common presentation, though, is acute kidney injury. So our patient, where are we now? With fever, no significant extrarenal features, except lymph node was there, non-oliguric AKI, history of multiple drugs. So still we don't have a clue. It may be anything. So how do we proceed further? We go with the examination. Now, first is the urine examination. And commonly, what do we see in AIN? We generally have minimal proteinuria. Nephrotic proteinuria is rare, except for the conditions I mentioned. You may have white cells, red cells, white cell casts. RBC casts are very rare. They are more common in glomerulonephritis. So common question is, can you have an RBC cast in ATIN? Some case reports are there, but very few. That's not the norm. Eosinophiliuria may be there. And remember, absence of urine findings does not exclude the diagnosis. If urine findings are there, it's suggestive. But if the findings are not there, you cannot rule it out. Urine findings are helpful because even if nothing is there, they help you to exclude the other causes of AKI. For example, ATN, muddy brown casts, they are not there in AIN. Then red cell casts in acute glomerulonephritis. And in pre-renal and post-renal AKI, you have a pretty normal urine. Whereas here you have minimal proteinuria, some sterile pyuria, so on and so forth. Sometimes, so this patient had a pretty bland urine protein was 200. The dipstick was positive and the semi-quantitative was like this. Urine RBC around 3, WBC 10, nitrite was negative. Now, eosinophils can be seen. This child, we couldn't find them. But remember, what do you call as eosinophilia? More than 1% of urine white cells eosinophils are known as eosinophiluria. But again, neither specific nor sensitive. May be present. If it's present, fine. But remember, it can be present in so many other conditions as well. ATN, crescentic glomerulonephritis, atherosclerotic disease, UTI also, schistosomiasis. So it's not specific. Neither it's sensitive. Our child didn't have this. What else? What next should we do? Urine examination did not reveal anything much. So complete blood picture, again, you may have eosinophilia, but remember, again, that's not universally seen. It's only seen in 25% cases. NSAID-induced AIN, very few have eosinophils in the blood. Again, infection, you may have leukocytosis, some toxic granules, etc. And sometimes schistocytes may be there if there is some hemolysis, but very uncommon. Here, what about this child? It was normal and CBP was not suggestive of anything specific. Then renal function test, creatinine was high, urea was high in this child. Most of the patients, as I said, have AKI. Liver function tests were okay. Albumin was 4, globulin was 4.5. So you have to remember that globulin was a bit high. Let us keep that in mind. ABG showed mild metabolic acidosis. There were no features of Fanconi syndrome. And the electrolyte disturbances were not many. Their electrolytes were normal, but some patients of AIN can have electrolyte disturbances. So you should do all the electrolytes because it affects the tubules. And ultrasound, there may be a marked enlargement of the kidneys. For this child, what was the abnormal finding in this lab investigation? Creatinine was 1.1, urea was high, and globulin 4.5. Does it suggest anything? Let us see. What about the ultrasound? This was the ultrasound. And it showed kidneys which were enlarged with patchy, low attenuated lesions. So let us see what does it suggest later on. So as of now, ATIN with some typical findings. The lesions, you can see the low attenuated lesions, and you have seen that the globulins are a bit high. How to proceed? What next to do? So X-ray to rule out sarcoidosis, tuberculosis. This boy had a normal X-ray. HRCT is done sometimes. In cases which are inconclusive for sarcoidosis and we have a strong suspicion. Gallium scan is not done, but it has been suggested in some papers. It just shows an increased uptake, but again, it is not diagnostic of anything. We tested for infections. So ASO negative cultures, urine antigen, you can look for Legionella, urine cultures, leptospira you rule out, fungal infections, viral infections. So we did some of the profile and everything came back negative. What do we do next? We look at the special tests because apart from drugs and infections, you have collagen vascular diseases as cause of AIN. Here again, everything was negative. The Silly profile, Jobrin's profile, ANCA negative, sarcoid, nothing was positive, and slit lamp was negative. So everything was negative. Only thing was complement. C3 was borderline low. So where are we again? Is it suggestive of anything? What next should we do? So as we did not come to any clear conclusion and the child was not improving, biopsy was done. So should we do biopsy in all cases of acute interstitial nephritis? No. There are specific indications. All acute renal failure cases, no. But if they are not improving, you have to do a biopsy. Clinical picture looks like AN, but there is no offending drug. Then you have to do a biopsy. Clinical picture looks like AN, but the urine analysis is absolutely normal. Then also you might go for a biopsy. No improvement in 2 weeks after withdrawal of medication, before steroid therapy, and if there is nephrotic proteinuria. So in this case, the child was not improving and underwent a renal biopsy. Typical biopsy shows interstitial edema, interstitial infiltrate, tubulitis, glomeruli, tubules, and vessels are normal. So it's tubulointerstitial nephritis. This is the typical hallmark. And you may see some glandular staging of immunoglobulins in allopurinol, NSAIDs, phenytoin. So this child, what did the biopsy show in this child? So this is a typical picture. Sometimes you can see this typical picture. You can see that if you have cells, you can have interstitial edema. Some cases you may have early granuloma formation. What about this child? Let us see. So if you have a granuloma formation, it shows that the infection is chronic or it's a long-standing disease or some systemic disease. So if you have granulomas in the interstitium, think of sarcoid, think of drugs, think of infections like mycobacteria, fungi, bacteria, for example, brucella, chlamydia, spirochetes, and parasites. These cause granulomatous interstitial nephritis. Vasculitis with interstitial nephritis, also you have granulomas, and some other causes you have granulomas. So this is a clue in the biopsy if you have granulomas. This child did not have these granulomas either. Then what is the child having? Let us see. So this was the biopsy of the child, which shows dense storiform fibrosis, with eosinophilic infiltrates. So this is suggestive of a disease called IgG4 mediated acute interstitial nephritis. I already told you he had elevated globulins. So that was a clue there. Then IgG4 levels, if they can be done, they'll come high. Hypergammaglobulinemia child had and hypocomplementemia. So this would have raised our antenna about this diagnosis. So how do we define this IgG4 disease? Elevated IgG, you have multiple low density lesions on the imaging. The child had that. IgG4 level more than 135 milligram per DL and characteristic storiform fibrosis on biopsy. So he fitted into this criteria for IgG4 related kidney disease. You may ask, it's generally seen in adults. Do children have it? Yes. Children also can have it. Once you have excluded malignancy, you have to think of this. It looks like a tumor mass, a gland, some swelling. Salivary gland involvement may be there, like thymal gland, pancreatic gland involvement may be there. Lymphadenopathy our child had. You may have lung lesions and enlarged kidneys, which low attenuated lesions, which our child had. And AKI is common, progresses to CKD if you miss it. As I said, can occur in children. 25 cases have been reported, mostly in girls. This is a paper from the West, and they have reported orbital involvement. And they said that you have to use immunosuppression for these children. So if we miss this, we will make the child go into CKD. What about India? You will ask. West, it's been reported. What about India? This is from your own Institute of PGI, Chandigarh, where they have reported this quite recently, 2019. So this is in India as well. We are missing it if we are not diagnosing it properly. So we have looked at the etiology. We have looked at the clinical characteristics. We have looked at the lab diagnosis, and we have reached a conclusion in our index case that the child had IgG4 mediated disease. What causes acute tubulointerstitial nephritis? Very simple. It is an antigen antibody reaction. And from where does the antigen come? It can be an endogenous antigen. Megalin, which is a part of the tubular basement membrane. You can have antibody to that. It may be an exogenous planted antigen. It may be a drug or some microbial antigen which gets deposited. It may be an exogenous processed antigen. The exogenous antigen is processed by the tubules and then causes an inflammatory reaction. Or it may be a hapten. A part can bind to a normal component of the basement membrane of tubule and cause this reaction. Thus, it's cell-mediated immunity. Along with antibody-mediated immunity, you have inflammation, complement activation, release of mediators, interstitial nephritis, and if you don't catch it and treat it, you have CKD. It's not dose-dependent, it's predominantly idiosyncratic. So can occur in some, may not occur in others. And this is the picture which shows on the left side cell-mediated mechanisms and antibody-mediated mechanisms, which finally end in damage to the interstitium and the tubule. Fine, so we've discussed that. How do we manage it? Very simple. Look at the cause first, remove all offending agents, remove all the drugs. So everything was stopped for this child. Manage the infection, identify and manage. So these are the basic tenets of management. You should not rush with the steroids or any immunosuppression before you do this. What are the role of steroids? So generally in drug-induced AIN, it's not required. Withdrawal of the offending drug is most effective, and the addition of steroids does not alter the clinical course. Try to avoid subsequent administration of the same drug. When are the steroids indicated? If the AKI persists for 1 to 2 weeks, even after the drug has been withdrawn. If ATIN, you are not able to find out any cause, it's idiopathic. In TINU, the tubulointerstitial nephritis with uveitis, which I had shown, AIN associated with systemic diseases like sarcoid, SLE, etc., and AIN with IgG4 are index case. They are indicated. We give methylprednisolone 5 to 7 milligram per kg per day for 3 consecutive days, followed by oral prednisolone, and the whole course is for 1.5 months. And this is how it's been described. But remember, steroids may hasten recovery in severe disease, but long-term outcomes with or without steroids have been found to be similar in many of the articles. Another question asked is, if the patient is not willing for a biopsy or not fit, can we give steroids? Yes, if you have stopped the drug and there is no improvement at all, some papers describe starting steroids at 7 days. And after giving steroids for 7 days, still there is no improvement, you can again do the biopsy at that point of time if the patient becomes fit. Do not delay the steroids till very late. If you lose the window of opportunity, it's not going to work. So it's a very delicately balanced decision. If the steroids do not work, there's no response, then you can go for other therapies. Mycophenolate mofetil in steroid dependent on recurrent AIN, plasmapheresis and other cytotoxic drugs in anti-TBM disease, and cyclophosphamide and cyclosporin in ATIN resistant to steroids. So many options have been described. What about prognosis? Older age, bad prognosis. Children generally have a favorable prognosis, provided you pick up the etiology and treat them adequately. Long duration of AKI, poor prognosis. If the child has baseline CKD, poor prognosis. Initial dialysis dependency, poor prognosis. And on biopsy, degree of IFTA, neutrophil or macrophage reach, infiltrate, and granuloma are bad prognostic factors. The severity of AKI does not have an impact on the prognosis, provided you treat it properly. If you don't treat it properly, over a period of time, what happens? The child goes into CKD or chronic tubulointerstitial nephritis. And it is caused by many other things, but it may be an important sequel to acute tubulointerstitial nephritis. So what is different in the biopsy in chronic tubulointerstitial nephritis? Again, you have so many cells infiltrating the interstitium, but here you have mononuclear cells, and you have 2 typical findings. Thyroidization of tubules, they look like thyroid gland. You can see the colloid in the tubules, and periglomerular fibrosis. So how does ATIN differ from CTIN? Infiltration is there, but here thyroidization and periglomerular fibrosis, which is never seen in AIN. And what happens to this ATIN? As I said, untreated, undiagnosed cases progress to CTIN. But here I will just take a minute to tell you that CTIN is not always a consequence of ATIN. It can occur in so many other conditions. For example, long-term analgesic use, lead nephropathy, oxalate crystals, hypercalcemia, hyperuricemia, metabolic disorders. They can cause CTIN directly. Initially, they may start at insults of ATIN and progress to CTIN. Apart from that, radiation, chronic radiation, it may straight go to CTIN. Endemic nephropathies, repeated exposures, Balkan nephropathy, Chinese herb nephropathy, Udanam nephropathy, Tondai Mandalam nephropathy, now described in India. Remember, important causes of CIN. They may start initially as small insults, lead to CIN because missed. And then you have inherited disorders which can cause CTIN. So what is the end result of ATIN? If we don't treat properly, it is one of the important factors which can contribute to CTIN. And I would like to emphasize that it's one of the treatable factors, the preventable factors. CTIN is fast becoming the commonest cause of CKD in our country. We use the term CKD-U for many of these unknown insults. So this is fast becoming an important cause, and our ATIN contributes to these. So this is just a brain teaser at the end of my presentation. If you have an interstitial nephritis picture with these findings, what's the diagnosis? So what's the first figure? So it's not a physical conference, otherwise I would have pinpointed and asked the postgraduates. I can't do so, unfortunately. So first one is papillary necrosis ring sign in analgesic nephropathy. This one is oxalosis, nephrocalcinosis with interstitial nephritis. This is blue lines gum and biopsy showed interstitial nephritis. This is gouty arthritis. You can see the tophi and interstitial nephritis, and atheroembolic disease. You can see the cholesterol clefts with interstitial nephritis. So if you have interstitial nephritis with any of these pictures, the diagnosis is a spotter, and we should never miss that. But these are more commonly chronic. If we miss the acute, we land up with chronic. So this is our data concluding. So I have shown that in UK, they had over a period of 10 years, 8 cases. And what does our data show? Over a period of 10 years, 3,325 biopsies, and you can see 16% ATIN. So ATIN in India is quite common, and predominantly because of infection and drugs. So I would like to acknowledge Dr. Soundararajan, pathologist, and Dr. Chetan Shakti for collecting the data. So this is a huge data, which we are in the process of publishing. So I come to the last slide of my presentation. Learning points, ladies and gentlemen, ATIN is common. Be aware of it. You can treat it. It can present in multiple ways: AKI, acute nephritis, tubular dysfunction, so on and so forth. And in India, we should be doubly aware because drugs, one-side insulted drugs, infections, autoimmune diseases, malignancies, they come down lower in the list. Generally, the sediment of urine is bland. RBC casts are not there generally. Coming to diagnosis is important. And when you are in doubt, always biopsy. You have that important tool in your hand. Steroids judiciously should be used. And if you don't treat properly and we miss the diagnosis, we miss the bus. And these children progress to CTIN. So ladies and gentlemen, that was the last slide. And thank you very much for a patient hearing. So I would be happy to take any questions. Thank you again for the opportunity.
Thank you, Dr. Manisha Sahay. That's an excellent presentation. I think, as you rightly mentioned, CTIN, it's not only Chinese herbal nephropathy, Indian herbs also do mischief, right? So whenever my AN patient, we don't find the usual checklists are collaborating, doesn't give the usual, any clues from the usual checklists, I always ask for alternate medicines. Alternate medicine history, especially acute AKI of unknown origins or unclear origins, we always ask for alternate medicine. That's an excellent question. As a moderator, I take the privilege to pose one to Dr. Mattoo. How often you use your indomethacin and hydrochlorothiazide in your RTA cases? No, it's up because we are all, as adult nephrology, we are obsessed with indomethacin. We're obsessed with this combination of indomethacin with NSAID, the diuretics. How often you use nearby?
Yeah, before answering your question, I want to tell Dr. Sahay, I really enjoyed your presentation. Very informative and excellent slides. Thank you.
Thank you, sir. Thank you.
Yeah, I don't remember using indomethacin, but hydrochlorothiazide I have used quite a bit. Again, because of the tolerance of patient tolerance for the amount of bicarbonate they need in proximal RTA.
Excellent.
So thiazide, yes. Thiazide quite a bit. Indomethacin, I don't remember.
Thank you. And how is the utility of the place for doing so-called acid load tests in diagnosis of incomplete RTA? So there is a place for doing acid load tests with a normal renal function.
I haven't done that for 30 years.
Yeah, we have been doing it as registrars, no? 30 years back. Is there
Right,
a place for
right. Yeah, I did that as trainee, yes, yeah. But no,
right.
There's no need to do any of those tests. Yeah.
Okay. There are a lot of interesting questions in the chat box. Probably
I can see.
Will take,
yeah, I can see a few questions there, but let me start with the first question. We have seen, this is Dr. Sinha. We have seen multiple children with proximal RTA having positive urine anion gap. So can we differentiate proximal RTA and distal RTA from urine anion gap? Well, urine anion gap is not a perfect test. There are limitations. I didn't get into any of those. What I said was what's applicable to most people. And there are some people who wouldn't believe in urine anion gap at all. There was an article published in, I think it was ASN Journal, I think about a year ago, about the limitations with urine anion gap. And that's understandable. First, it depends on sodium, potassium, and chloride intake and what's happening with those anion and cations in the body. And then also, as I mentioned earlier, it's an indirect marker. It's not a direct marker for ammonium excretion. So there are many things that may sometimes not give you accurate urine anion gap. But in most cases, yes, it does help. And I would not base diagnosis of proximal RTA entirely on what the anion gap is. And one may have to look further into such a patient. You may want to do urine osmolar gap, for example. That might help a little bit more, and see what that tells you. And then, the kind of sophisticated tests I mentioned might also tell you, you have to look at the patient, what else may be going on with the patient that could be causing this. And then the last thing is that this may not be proximal RTA. I don't know how much bicarbonate these patients are on. If they are on a smaller dose, then this may not even be proximal RTA. The next question is, what's the acceptable level of sodium bicarbonate in case of proximal RTA while on therapy? Well, the way you have to look at proximal RTA is a water bucket. And I think Dr. Jain is going to smile because he must have heard me say this a million times. Think of a water bucket which you are trying to fill. The difference is that this bucket has a hole. And you are standing there trying to fill it, and you have a hole there that's leaking water. And if you fill it at the same speed, same volume as it's leaking, then it will never get above the level where the hole is. It's only when you fill it more than that, the leaking will continue.
Dr. Mattoo, you remember the song, The Hole in the Bucket?
You fill it more than that, you keep up the level, and you have to keep filling it because it's constantly coming out through that hole. So you want to achieve a normal serum bicarbonate level, which can be very tricky, as I said, depending on what time you do the labs. These patients, they don't hold on to bicarbonate. It's not like an antibiotic that will stay in the system for 24 hours. The moment you give bicarbonate, the bicarbonate excretion in urine increases. And if you are giving someone medication every 6 hours, I can bet, if you do labs after 5.5 hours, it's going to be subnormal. But then if you do the labs immediately after you give it, it could be higher than normal. And that's where the urine pH comes handy. So you want to keep the serum bicarbonate as close to normal, preferably in the normal range, depending on what time you are doing the labs. But keep an eye on urine pH. You don't want to make it too alkaline. Any limitation to bicarbonate dose in proximal RTA? Yeah, patient tolerance. Because patients sometimes, particularly younger kids, don't tolerate it. They may throw up or they may not like the taste. And, ideally, if you want to be very physiologic about management of RTA, proximal RTA particularly, you would want to have patient on bicarbonate infusion. Because then you know how much is leaking and how much additional you need to give to maintain a normal level. But that's not possible. We can't have these patients on continuous IV infusion. And with oral administration, we know that it's going to be up and down depending on what time you give it. So there's no limitation. You want to keep the level as close to normal as possible. But the only limitation, I've experienced is patient tolerance. And then the other question is, let me try to pull it up. If chloride acts as a surrogate marker of acid excretion, then shouldn't the urine anion gap be negative in normal individuals because they do have a normal distal? Well, Dr. Bharti obviously was listening to my talk. Under normal circumstances, we have more sodium and potassium than chloride. And that's what comes out. So that's why it's normal. That's why the normal anion gap is positive, because there's more sodium and potassium that we take. It's the chloride that gives us the negative balance, negative urine anion gap. And that increased chloride that you see in RTA is because of increased ammonium excretion in proximal RTA. On one hand, in proximal RTA, you have problem with bicarbonate reabsorption, but then the distal tubule is normal. And it tries to compensate by getting rid of more H ions, which is ammonium joining H ions, ammonia joining H ions, and in the earlier stages, phosphate joining H ions. And ammonia comes out as ammonium chloride. So you have more chloride. That's the reason it becomes negative. When you have more than normal H ion excretion in the distal tubule in acidosis. But under normal circumstances, we have more sodium and potassium. That's why it's normal. I hope I answered your question. Ideal time to check urine pH. Well, it depends on what time the child pees, but it doesn't really matter. That's an interesting question, actually. I mean, let's say you are in a situation where you are doing a cat specimen. It might be interesting to see what happens to urine pH soon after patient gets medication versus many hours after patient got medication. But no, there's no timing. For me, the patient is the clinic, just get a urine specimen. The key is to dipstick it as fresh as possible. You don't want it standing, sending it to lab, the pH is going to change. So the moment the kid pees, do a dipstick. That's what's going to be the most helpful. It doesn't matter what time it happens. It may be sitting in the bladder for some time, but in a bladder, there's no exchange of gases. And that's the basis for the urine minus blood PCO2 test that you may have heard about and that we used to do as trainees and collect urine in a tube with some oil. And again, you don't need to get into all that. So as long as it's in the bladder, nothing is going to happen. But the moment it comes out, you want to test it as quickly as possible. The timing doesn't, it doesn't matter what time the child, we can't tell the child, okay, you have to pee in 1 hour for this test. We don't need anything like that. Is it must to see early morning? Not really, no. No, you don't need to. It doesn't have to be early morning. The morning urine specimen is most helpful for concentration. So if you have someone with any kidney problem and you get first morning urine that's not well concentrated, then that may be indicative of a kidney problem, but not for something like this. How should we supplement potassium in RTA? Well, it depends on blood levels. And then you give it, again, we have to, as pediatricians, we are so conscious of family convenience and compliance. So generally, we try, Dr. Srivastava wants to say something.
I remember outpatient 13-year-old girl who had bouts of paralysis, seen by the adult nephrologist, labeled as familial periodic paralysis. It was found to be distal arterial. And we remember doing in old times ammonium chloride loading tests, measuring ammonia. And I remember, I still have the records with me. Hypokalemia is not uncommon in distal artery.
Right, yeah. So, so how should we supplement? Yeah, so we talked about potassium as KCl syrup will further increase chloride levels. No, you don't need to worry about chloride levels. Don't connect it with chloride for urine anion gap. The two have no relationship. Don't worry about how much chloride you are giving to the patient as medication. Yeah. Then we have another question. I have a patient with distal RTA, hearing loss, sibling affected nephrocalcinosis, alkaline urine, hypokalemic metabolic. However, this patient is suffering from severe hypophosphatemic rickets. Can acidosis be the cause? Absolutely, because as I said, under normal circumstances, the H ion that you secrete in the distal tubule primarily buffers with phosphate. And it picks up more speed as we become acidotic, but then ammonia actually starts working harder, and that matters a lot more when we have acidosis. So yeah, that's a possibility. And obviously you will have to monitor that and see what happens as you treat the patient. And if that's the case, it would be getting better. And then also if someone has had severe bone disease and you are treating the patient, what we sometimes call hungry bones, the bones may pick up phosphate and that may also drop levels sometimes. So that could be another explanation for something like this. The next question, how long do patients with RTA maintain normal renal function when they are on regular treatment? Well, if you treat them well, and this is RTA, they should have a normal lifespan of their kidneys. The only problems can be if the patient is not managed well and gets nephrocalcinosis, nephrolithiasis, secondary infections, obstructions, kidney damage, scarring. Yeah, those patients could end up with end-stage kidney disease. In proximal RTA, again, if you manage patient well, there's no reason why the kidney function should not stay normal. How calculate dose of sodium bicarbonate powder from rather than the tab? Well, I don't understand that question, but whatever bicarbonate, I remember I got a call from Yemen when trouble there started many years ago. And it happened because, as I said during my presentation, Detroit is very close to Dearborn, and we have quite a few Middle Eastern patients there. And one of my patients' moms, her cousin from Yemen, she called me because this mom here heard from her cousin that they were having problem getting sodium bicarbonate. And so they were talking, and this cousin told her, if you should try to call me, and gave her my phone number without even telling me that she had given my number to her cousin. So anyways, so she called, and turned out to be a very educated person. I was very impressed by her knowledge base. So she told me about her child and told me the problem she was having. And the answer was very simple. I said, just use baking soda. Because baking soda is sodium bicarbonate. So I don't remember now how much you have in 1 teaspoonful. Professor Srivastava may remember that. But it's very easy to figure it out. So you can use baking soda if you don't have bicarbonate. Now, I'm not saying that you should be doing that, but look at your own place, see what concentration it is, and starting dose is generally 2-3 milligrams per kilogram. Use of potassium citrate. Yeah, I mean, if you have hypokalemia, you are better off potassium citrate. Sometimes tolerance is better with potassium citrate. And then also if you have a liver problem, then, straight would work better. Any limitation for bicarbonate dose? No, there's no limitation. You see the fractional excretion of bicarbonate, and you all heard about the fractional excretion of sodium around less than 1%. For bicarbonate, it's around 5%. So whatever gets filtered at glomerulus, about 5% comes out in urine, 95% goes back into the blood. And in patients with proximal RTA, it's generally about 20% or maybe even more. So you have now 20% of what gets filtered coming out. So you have to give enough to correct the serum bicarbonate level. Physiologically, whatever it takes, but I know tolerance can be sometimes an issue, and that's where the possibility of thiazide or indomethacin comes in. But there's no other limitation other than patient tolerance. And I think that's the last question.
Thank you, sir. I think Dr. Manisha, we have an interesting question for you about your experience. I know you got a publication about the rickets in tropics, no? The RTA. Can you throw some light on that?
Yes, sir. So, sir, Mattoo sir was asking for data from India, sir. So we had worked on this. My husband is an endocrinologist, sir. So both of us were interested in this. And I did pediatrics and then joined nephrology. So we have analyzed our data. I think it was around 120 cases of rickets coming to the Department of Nephrology after having failed therapy for nutritional rickets. And in that series, it was published in the Pediatric Endocrinology Journal. So there we had most common cause we had was distal RTA, and around, if I remember rightly, it was around 65 to 70% of the rickets which we found in our OP was distal RTA. Then we had around 20% for hypophosphatemic rickets actually, and proximal RTA we had less number of cases. So the vitamin D dependent rickets we have again few number of cases. So vitamin D dependent rickets type 1 and type 2 both. So among the RTA, distal RTA is quite common. I mean, it's often missed, and you have seen the interest your talk generated. So all questions about RTA. So it's quite common. And then proximal RTA, I mean, in India, in infants, if you have proximal RTA, most of the times it's because of cystinosis, which is treatable, but somehow it's missed in infants. So, I mean, that's one of the treatable causes. And even in government hospital OPs, we ask for a slit lamp, which is easily available because we are not able to check the cystine content of lymphocytes and all those things, not able to do. So slit lamp helps with the diagnosis, though it's not 100% sensitive, but it's a useful tool. And we have published case reports in Kidney International based on slit lamp examination in small children coming to OP of our government hospitals. So we work in a resource limited setting, and we have to go more clinical rather than lab based. So that's our experiences. And as you rightly pointed out, if you treat the rickets properly and give adequate correction, just not write the treatment and forget, but you have to follow the child. The growth of the child is the most important indicator. These children showed dramatic improvement, and they really do well. Then you have to look at the calcium creatinine ratios in the urine, prevent nephrocalcinosis. So you have covered the points very nicely. We often do the acid load test in our labs whenever we are in doubt, whenever we have case of incomplete RTA. As going by the questions generated, I think this is still, it remains a topic which is less understood by most of the fellow residents. As they go by and with the aid of such seminars, I think they learn a lot more. In fact, I think Dr. Ganeshan can plan a separate topic on RTA itself with case-based discussions. So maybe that would be really a great idea. And thank you, Dr. Mattoo. It was great learning from you.
Well, that's excellent work. But the question I have is, have you or anyone else looked at RTA in patients with nutritional rickets, which is a well-known entity? And I have seen, I don't know, Manisha, I don't know if we had any case since you came on board, but I have seen 2 or 3 cases here in Michigan with straightforward nutritional rickets.
Yes.
Having some element of proximal RTA, and you treat their rickets and with vitamin D, and the RTA goes away. So has there been any study on that in your center or anywhere in India?
So not specifically looking at that, sir. That's an excellent point. But here what happens is the patients first go to the pediatric hospital which is another hospital here. And there, generally they treat for nutritional rickets, and then they even follow those protocols where they give the vitamin D, even the massive dose of vitamin D, look for the zone of healing. And after that dose, if there is no healing, and after ruling out other causes, for example, malabsorptions, anti-epileptic drug intake, the child doesn't do well, then we get the child under the label of refractory rickets. And that is why the rickets which we see,
right.
spectrum which comes to us. But what point you made is an interesting point, because many of the nutritional rickets cases, maybe they partly respond to the nutritional therapy, maybe wholly they may be responding. But in case, you make an excellent point, if they are not responding completely, maybe it would be worthwhile looking at their, the other cause of rickets in them as well. Both can coexist.
Yeah, no, thank you, Dr. Mattoo, for that comment. And
Mattoo,
as you said, we have only.
Go ahead, sir.
Can I say?
Sorry, go ahead.
I can say a few words.
Yes,
Yeah,
Dr.
please.
We
Namal,
have
please
seen,
go.
I still remember, we have seen a child with type 2 RTA, secondary to vitamin D rickets. Then we looked up the literature long ago, small prints in some journal. I'm not able to tell you right now. We found they have already described many years ago before I found it. It does happen, but that's very rare. I told you, only one case we remember in our experience. I think Kalaivan, I don't know whether she remembers, they happen to present it in one of the clinical meetings also. I don't remember the details, but that's how it does happen. But it's very rare.
Yeah, but the reason I mentioned, in my presentation, if I could see a couple of patients here, there must be a lot more in India. And once they get treated for rickets, it's going to, bicarbonate is going to normalize. But I don't know how much data is out there, but it must be a lot more common in India than in here. Yeah, thanks.
Yeah, no, thank you, Dr. Mattoo. And that's what I was going to say, that, yes, we did see a few patients here. And since, as you mentioned, we do have the Arabic population as well, and it would be very interesting to collaborate and see, what we are seeing here and what we are seeing back home in India. The other interesting thing we could also look at is how quickly do they respond to the treatment? I mean, I know we talk about the vitamin D resistance or vitamin D dependence, but not just rickets, but how quickly the RTA itself responds. Do they need to be on the supplements or not? I think those would be some interesting points that we can all learn from. So thank you so much, Dr. Mattoo, for the comment. And I can tell you that each time I hear your lecture, I think I still have so much to learn. So thank you. And I thank you for your excellent lecture.
Come on, I mean, with Professor Srivastava here, you are embarrassing me. So,
Dr. Manisha, how common is IgG4 nephropathy or disease? I mean, it must be rarely with us.
Sir, it's being picked up now. In fact, it was not picked up earlier because we were not doing the appropriate thing. So in fact, I thought there won't be any case report from India, and at least in pediatric age group. But again, you are having reports in pediatric age group from institutes in our country as well. So the article which I showed, so that is, that has reported total 3 cases in India so far, which have been diagnosed recently. So probably, we must have been not picking it up because soft clues were there, hypocomplementemia, and again, if the globulin levels were a bit high, but otherwise we do not do the IgG4 scan at all. In many of the centers, it's not available. So if you are not able to do the scan, and if people are not aware of the pattern of fibrosis, the storiform fibrosis, we would be completely missing that entirety. So, that was one of the index cases which I had taken. But as you rightly said, it's more common in the adult population. Overall itself, it's a rare disease and upcoming entity, and probably in the years to come, we may be hearing more and more about it.
I think I should congratulate you for you are one of the largest series of biopsies documented cases. No, you humbly said it's a resource limited. No, I think you are a treasure of cases, right?
Human
rich in cases.
The human resources there, sir.
Yeah, I think I should congratulate you for your largest number of publications and biopsies from Uxmania. Professor Srivastava, I think you have got something to say, sir.
I enjoyed the whole sessions actually. Every time you just learn something more. Every time we learned. I was thinking of that song, Dr. Mattoo, The Hole in the Bucket by Harry Belafonte, the old song. remember that. Thank you very much. I really enjoyed this. Thank you.
Thank you, sir. Thank you, all of you. I think Dr. Kalevani to take over for your further to take over. I will.
There is one question from Dr. Arpita sir for Manisha ma'am. Is it okay to take up the question now, ma'am? Manisha ma'am is there?
Yeah,
Yeah, she's there. Please go ahead. Go
Yeah,
ahead.
so she's asking when there is a diagnostic dilemma between tuberculosis and sarcoidosis as a cause of GIN, how do you proceed with treatment? So we do whatever investigations are available at hand, everything, I mean, including the ACE levels, and we try to biopsy whenever we have a chance in lymph node. So caseation makes a diagnosis in favor of tuberculosis. We look at exposure. But again, having said everything, if the child is having a weight loss, fever, not vaccinated, sometimes we go for an empirical trial of ATT, and rifampicin is one of the causes of granulomatous interstitial nephritis. So sometimes in those cases, we try getting anti-rifampicin antibodies as well, everything negative. We give a trial of ATT without rifampicin. There is no guideline. I mean, such guidelines as Dr. Amrish was telling, we need some data on RTA. Similarly, this data on interstitial nephritis because of ATT has to come from where? From our own country. So I think, I mean, and guidelines have to be formed by us only, because this is very rare entity in the Western world. So as of now, what is being done is, I mean, after exhausting all the options, we sometimes give a trial of ATT. I won't say that's the first option. I won't even say that's the ideal option, but sometimes we have our backs against the wall. So I think, I mean, we need to come up with guidelines, because there are so many other questions. For example, the patient develops interstitial nephritis after rifampicin, and again, second time, and the patient is a confirmed case of tuberculosis. What do you do? I mean, second time, do you re-challenge with rifampicin? So again, I mean, there are papers which say you re-challenge once, but again, if you have the same problem, then do not use rifampicin, go for rifampicin excluding regimes. So many ifs and buts are there, but as I said, this niche area where infection related, especially tuberculosis related glomerulonephritis, I think we should collate the data from different centers and probably come up with our own guidelines.
I have my own question. Is there any role of steroids in that case, ma'am?
In which case, so if it's a proven infection, you treat the infection, and along with that, steroids can be given.
Okay. How long do we continue steroids in?
As I said, the guidelines say 6 weeks.
Okay. Okay, fine. I think we are done with the excellent discussion. We had an extraordinary discussion. Thank you so much. Next, we have the exciting session of polling session. It's meant only for the trainees and the pediatric trainees and fellows. If panelists are interested in staying back, it's okay. Like, we'll have the polling session now, and I'll just run through the instructions for the polling session. So the participants are requested to enter their proper email IDs and contact numbers, because that is the only source of our communication. And the total polling sessions, we'll have 6 polling sessions, and the dates are mentioned below. And each polling sessions will have 10 questions, and it's mandatory to answer all the 10 questions to proceed with the submission of the form. And total duration is going to be 10 minutes for the polling session. And we will have 3 star questions in each session, and the star questions are considered only in case of tie, and the cumulative score of all 6 polling sessions are going to be taken for choosing the winners. And once you log into the webinar, you can access the polling session. You don't have a separate link for it. So we'll move on to the polling session now. Like, if panelists are interested in staying back, it's up to them to stay back, but we had an excellent discussion. Thank you so much, Manisha madam. Thank you, Srivastava sir. Thank you, Soundararajan sir, for moderating the session. Dr. Amrish, like, whoever wants to stay back, it's fine with us to stay back, but we'll have for next 10 minutes.
I don't want to be impolite. I mean, what do you do in this polling station, and how long is it going to take?
It's just going to be only for 10 minutes, sir.
Okay, I can wait 10 more minutes. It's okay. Yeah.
After that, we'll be closing the session. So we.
No, it's fine. I mean, I wasn't sure, how this process works. And
Yeah, it
as
is
I
for the
said,
trainees only. So only
Yes, ma'am.
trainees are going to be participating in the polling session. I think I'm staying back to learn more. So.
Okay, fine. I'll stop sharing. Can we publish the questions now? So the total duration is only for 10 minutes. Hope the participants are able to view the questions. The time starts now.
Are we going to see the results?
We have 3 more minutes for the polling session to end. We have 1 more minute. Last 30 seconds left. So we'll end the session. The polling session is closed for now.
Thank you so much, Dr. Kalavani. And in the end, I would again like to thank all the speakers, moderators, chairperson. Again, thank you, Dr. Mattoo, for sharing all your wisdom on RTA, Dr. Sahay for talking to us about tubulointerstitial nephritis, and Dr. Srivastava for all your guidance, not just for this session, but throughout the years. And I would also like to thank Dr. Soundararajan. I think he had to leave. But thank you again all for joining. This would conclude our session. Dr. Srivastava, do you want to make any last remarks? Dr. Srivastava, you're muted.
I guess my about 50% may be correct. That's about it. Thank you. I really enjoyed the session. Dr. Mattoo, thank you very much. Missing you so much.
See you soon. Yeah, good.
Thank you, Dr. Kalavani. Thank you very much.
Thank you so much. Thank you,
Bye.
Mattoo. Thank you, Srivastava.
Thank you, everyone.
Dr.
Thank
Manisha
you, all the
Everyone,
participants.
thank you for the opportunity. Thank you.
Thank you so much, ma'am. Thank you. Bye-bye.
Bye-bye.